So with that note, we start with our top 10. I always start with the paying the tribute to Alan Cribier, as you know, who died about 2 years ago. Started this process. It started with Anderson, with a lot of sheep experiment, and then, of course, percutaneous treatment in April 16th, 2010, 2002, and now we actually have come all the way, and we did the first, the Evolute or core valve, actually, we call it on December 18th, 2010. So now what has happened is, we all know, just like a coronary artery disease, the valvular heart disease also have spectrum, stage A, B, C, D. As you can see, at risk, progressive, asymptomatic, severe, and symptomatic severe. And we all know, until few years or few decades, I would say maybe 1.5 decades and above, earlier, all treatment or majority of the treatment for structural heart disease was surgical. And therefore, we are waiting for symptomatic severe to develop. The question always comes that do you need to wait symptomatic or become asymptomatic, particularly if you have a transcatheter option, which is less invasive and safer. So that is where the field is going. Asymptomatic, whether with some dysfunction or not dysfunction, and then what if? Why you even have to wait for severe symptoms? Because we know the disease progresses, myocardial damage occurs, fibrosis occurs. So no need to wait till knowing the disease will progress. So maybe intervene a little early, particularly moderately severe, but symptomatic, not asymptomatic. So the field of valvular heart disease is, I would say, evolving, expanding, and the latest guidelines from the 2025 European Society touch on some of those aspects which I'm going to share in my top 10. Now, one thing clear, TAVR has become the default therapy. Why? Because last 20 years had done multiple trials, 8 of them in various subgroups, and basically showing that TAVR was not only non-inferior, in some situations superior to surgical valve replacement. Of course, one case did have a higher stroke, but never happened subsequently. Then, therefore, now, because TAVR has become the dominant and the safe and preferred default strategy in management of symptomatic severe AS. Symptomatic, severe, including low flow, low gradient AS, which apparently occurs almost in 20+% of cases. And now question comes, which patient should get surgery, and particularly patient with the adverse anatomy. Now, the growth of TAVR is tremendous, as you can see here, which is our orange line. And now about 10,000 TAVR procedures are being done every month in the United States. So it will be about 120,000 in 2025. Now, surgical valve, which is here, at one point used to be, clearly as you can see here, some decline occurred, but only after some time. Basically you see that in the early time period, when the TAVR growth occurred, there was no decrease in the surgical valve. And this is a very important, showing that there was a technique, procedure, which really offered treatment to the patients who are not getting any treatment before. And of course, right now the market share is about 70 to 24 and 4% here. Now, the question then comes, the factors determining strength of when do good surgery versus TAVI, which is more than 20 years or less than 10 years, basically in between life expectancy. Knowing the guidelines basically are 65 years, less than 65 for surgery, more than 80 for TAVR, and in between you make a heart team decision. So this is basically rough outline. But we also learned almost 50% of the patients undergoing the aortic valve treatment in United States are getting TAVR at less than age of 65. So almost 50% less than 65 for whatever reason is happening at this time. And this basically puts it together that the anatomy is one of the very important factor. That if it's a good anatomy, you can extend the TAVR even to a younger people. Because what's the issue? A degeneration 10 years, then you do a second. By the third time, you probably will find out some kind of a gene technology to prevent the progression of the valve degeneration. So therefore, it can go to early, and maybe the valve leaflet can be more durable. So therefore, the whole issue comes is that the surgery, more so patient, or I would say TAVI, not TAVI, in the patients where there is an anatomy not suitable. If anatomy is suitable, you can extend that to an earlier uh, stages. Now, doing a tower alone is not enough. Now we optimize. By optimize in the coaxiality, expansion, orientation, depth. So clearly you need to make the better job. You need to do a perfect job after coming out of the percutaneous valve, just like we do for coronary intervention. And that is why PCI against surgery, even in the left main, many of the trials have shown equivalent results. Why? Because PCI did very good job. So same way, in order for us to have this dominant technology, tower as good as surgery, which has been there for 50 years, has to be that we are doing an optimal the tower procedure, so which is a long lasting. And we actually had a very nice review that beyond just severe aortic stenosis, various categories, which we, small annuli, young patient, asymptomatic, moderate, and some of them have been already answered by various trials, but the still remain few things. Bicuspid, new randomized trial is starting for the dedicated bicuspid with the good anatomy. Aortic regurgitation remains still the Achilles heel. The pure AI, the valve hopefully will be approved soon, and the moderate aortic stenosis. These are the future. So basically, let me quickly go through. The first one is cerebral protection devices. There are few trials which have been done because the stroke is part of aortic valve intervention, surgical or transcatheter. And we know that the surgery also has 4-5% risk of stroke. The tower has 3-4%. And we have shown that even your number increases over the years, that remain about 2-3%. Did not decrease. If you take a mortality graph, it will be like this, going down from 3% down to 1%. But stroke incidence remain the same. Why? Because stroke comes from various mechanisms coming not only from the valve, from the aorta, the debris, and of course, anytime you have the filter in the carotid by the sentinel, 99% you'll find something. But question is, taking that out, is it important? And that's what the field evolved into the cerebral protection devices, because once you get a stroke, mortality is 3-5% compared to patients who did not develop a stroke. So very, very important aspect, you need to prevent stroke. And there are two major trials. Protected tower, which I presented 2 years ago, 3,000 patients did not show difference overall. And then the BHF protected TAVI, which was presented this year, this from UK, large number of patients, about 7,500, and primary endpoint was stroke at 72 hours post-tower, and using the sentinel device. Here this sentinel come from the right radial to the right innominate and left carotid. Only thing is, left vertebral is not protected with this device. And what did they find? That overall stroke incidence was not different, but the disabling stroke, as you can see here, and question is the slightly compared to our earlier protected TAVI, the protected TAVI group, that there is a disabling stroke also was not different. The overall, rest of the endpoints are shown here. And if you take two of them, protected tower and BHF protect TAVI, here was different 7%, but the disabling stroke was better or lower in the protected tower group, but in the BHF protect large number of patients, even the disabling stroke was not different. So basically, you put two of them together, this is what we get. All stroke, no difference using this complex device, but there's 0.3% decrease in the disabling stroke, and that makes a p-value of 0.09. So what happened is, overall, while we have big excitement of using the cerebral protection devices, the numbers have gone down, and people say, what if? Not the stroke, but what about the cognitive function with this microemboli? And this actually has been looked into very methodical with a Montreal cognitive assessment with attention, language, abstraction. They did at time 0, and then about a few days later, and follow up for these patients, and showed that even the cognitive dysfunction or cognitive capability did not change by using the cerebral protection device. And they actually have all these individual types of the TMOCA endpoints, and therefore, so overall, use of the cerebral protection device has significantly declined. And there was another trial which we are part of it, it was halted. They stopped it because they felt it is not worthwhile. So overall, the use of cerebral protection in the TVT registry now used to be about 18%, now in single digits, and same number is at Mount Sinai. Second question, anesthesia choice for tower. Should you do general anesthesia or conscious sedation? And we actually had one trial, similar kind, done 5 years ago, Sol Tavi, and the latest trial of the double choice done for Germany, 2 by 2 factorial, peri-interventional anesthesia strategy, and was a different valve strategy. So here is minimalistic approach versus standard of care. And the local anesthesia, conscious sedation. Here, basically, you don't need a physician. Anesthesiologist, maybe nurse anesthetist can give, just like we do a balloon valvuloplasty. And then, of course, there was the second randomization of the accurate valve and evolute valve. But more important was anesthesia strategy. They went through all the points, what should be done and not, and basically found that anesthesia strategy, minimalistic or standard of care, no difference in terms of the major outcome, including death, vascular bleeding, infections, and any neurologic event. And these are the individual endpoints, no difference. And but only question was that they did have some more pain and discomfort. Clearly, because they're not totally anesthetized. That was the only difference. So patient reported symptoms, and of course for the valve strategy, this was for the valve of the accurate versus evolute, but accurate valve is no longer available. So basically, conclusion was that the isolated local anesthesia was non-inferior to standard of care with conscious sedation, highlighting the safety and efficacy of minimal anesthesia for TAVI. The burden of intraprocedural pain and discomfort is potentially higher in the MA group. So maybe we just have to sedate them more. Now, this is the SOLT TAVI data. This is for the valve, and this is for the 5-year data. Again, identical, no difference. So not only 30 days, which we saw in the double choice, and now even we have 5-year data of the SOLT TAVI, that whether you do a general anesthesia or conscious sedation is equal. There are a lot of new tower devices which have come. You can see every few years we'll get a new one, and they come with the randomization. Some of them are change of their existing valve, and classical example is the Ultra Resilia of Sapien, which is basically, because what happens to the leaflet? They get degenerated. But what if you can modify the leaflets some way so the less calcification and less degeneration occurs? So no longer the glutaraldehyde, but it's a separate technology of glycerolization, and it has shown in the surgical valve excellent outcome. 2 to 3% degeneration at 8 years, less than 5% degeneration. So if you can have same kind, you can put a valve, tower valve, is not going to last only 10 years, now could last 20 years. That whole field, when you should do tower, will change. So this is what the Resilia is, which is available now, and we have the paper from our institution showing that this did better compared to other valve devices of the Sapien. Then Evolute has come with a new design, particularly coaxiality and coronary access with FX and FX plus. Then particularly whether patients who have a small annuli, comparison of the self-expanding and balloon expandable continues, and self-expanding valve has shown superiority in terms of bioprosthetic valve dysfunction in the SMART trial, but outcomes were no different, but the valve area was better with the self-expanding at 2 years, but no outcome difference. But of course, 5 years will be a way to see. Another valve is the Hydra self-expanding valve. The data actually of the 30 days and now 1 year have shown very good simple device with the 1-year mortality of the 15%. So another valve is not coming to America yet, but it's available in few parts of the world, including India. The one which is very exciting is the My valve, and I was involved in development of this valve in India. Of the first 100 cases, we did 32 and first 5 there, and that's led the approval. The cost of the device is almost 60% less than the usual valve cost. You know what the usual valve cost is? $32,000. And this valve is available at present in 12,000, 12 to 15,000 based on the type and size, My valve. And that has really increased the tower use in India. There are multiple studies now have come, Compare TAVI, landmark studies comparing My valve with current generation, whether it's a Sapien or Evolute or any, showing basically identical outcome. And some cases maybe even slightly better in terms of the leakage. Very nice fit, because it's a design, because it comes in the 0.5 sizes also, 23.5, compared to our valves are 21, 23, 26. They comes in the half sizes also, and it has been a very good addition. Has not come to United States yet, but probably will come soon. The earlier data of the landmark, now they have 1 year data showing the same, that the my valve worked very well hemodynamically and the outcomes point to. What we really waiting is the GINA valve. And what is the GINA valve? Is the trilogy patient for pure aortic insufficiency, no calcification of the valve. High risk AI, and this is actually the two part. First, you have the alignment with the aligns, and then you deploy first the locator clip, and then you put the valve inside. Very good trial have been done and has shown good outcome. No randomization because these are high risk cases. Surgeons would not touch those cases, so therefore could not have any randomization. We have used our existing self-expanding as well as balloon expandable valve for severe pure AI, but selected cases only, because there's always an issue about the embolization because there's nothing to grasp. But this valve will be revolutionize those small percent of cases which are pure AI. And we have the data now, single digit 5 to 8% of the aortic valve disease in elderly we are talking about, age 65, 70, are pure AI. Otherwise, about 10-15% are mixed AS and AI, and remaining is pure aortic stenosis. But overall shows very good, except that high chances of pacemaker, as you can see here. But this looks like will be approved by first or second quarter of next year. So it's just around the corner. And only question was that who will sell it, and there was a whole issue with the Edward, our federal commission. They kind of stopped this merger. So somebody will take the company and will bring it to the limelight. The other valve, which is very exciting, is the Navitor, self-expanding, which is a change in the portico, and the trial was done, Vantage trial, very low event rate up to 1 year. Look at that, 3 to 4%, excellent data, and that led to that now the CE mark approved, and now we are a part of the trial Envision for the low to intermediate surgical risk patient, and this is about 1/3 done, and this is comparing the Navitor valve with the other standard valve. Last exciting in the valve is the Mirus valve, which is Seagull, which is the 8 French tower. Half the size what we currently use. 16 French versus 8 French. Same thing happening with our mechanical circulatory support, which is 14 French. Now we are going down to 8.5 to 9 French. Same way happening in the valve. 14 to 16 French will go down to half. Initial data look very exciting, but we need to see the long-term data. Then the tower versus surgery in all-comer AS patients in women, because women all shown that they have better outcome compared to men in our tower literature, 1 year, 5 year data. So what if in patients who are low risk, but all-comer, low to intermediate risk, all-comer, women versus men, in women cases, the tower versus surgery, and this actually is about 450 patients, primary endpoints, composite endpoints of death, MI, and rehospitalization, the decrease, although it's basically mediated by decreased hospitalization as shown here. But just to say, TAVI in women at 1 year was superior, and the blue bar, most of them down, means in almost every aspect, except probably the pacemaker, the TAVI was superior to surgery at 1 year. And this basically tells you that maybe there is the age of 70, heart team, you decide surgery versus tower. If women, probably go for tower rather than surgery. There's another trial called Dedicate, in all, again, low to all comers, low to intermediate risk, patient with the severe aortic stenosis, and that also showed that now the way we do TAVI, about 1,500 patients, blue bar lower compared to surgery. So all of a sudden now the trials are showing the better outcome of the tower in some selected group, women, all comers, low risk, and so with the tower compared to surgery. But again, this field will continue to evolve, and we already have established now that if it's appropriate anatomically, the patient, whether age of 65, 70, 75, should go for tower. Then SGLT2 inhibitor in AS post-TAVI. Clearly is that SGLT, any trial which have been done, almost every trial of the SGLT positive. Same thing is the DAPA-TAVI done by Dr. Fuster Center from Cynic with the DAPA-TAVI, and basically the 1,200 plus patient randomized to dapagliflozin 10 milligram versus no, and started and in the within 24, 48 hours after the TAVI implantation, an outcome at 1 year. A lot of patients have other risk factors. 50% were women, but basically shown that by giving DAPA, you have decreased event rate compared to control group. So in addition to what treatment was done, in addition to whatever the valve was used, that DAPA decreased the cumulative endpoints at 1 year follow-up. So very good news. But it basically was decreasing the heart failure, not by decreasing the mortality, but decreasing the heart failure, and in all specified group. So we another drug which we should be routinely starting in this patient. Question comes CAD management with TAVR. There a lot of data have been. Notion 3 trial, which I presented last year, showed that PCI with TAVR is better than wait and watch policy. And now we actually have the, what if you do FFR guided PCI? Remember the physiological guided that do lesion which are significant, not anatomically, but physiologically. And this is about the concept of the FI TAVI trial was. And again, about 300 plus patients had all got the TAVI, angio-guided PCI versus FFR-guided PCI, which was done. And if the FFR was more than 0.85 was deferred. And overall, what happened basically is that many of them were done during or post-TAVI. So this is a little different than our practice. When we do a PCI with a TAVR, we either do very early, wait 1 month, or we do post-TAVR. Majority we do post-TAVI. But in this case, the low risk patient, syntax score was low, simple disease. The majority of the done 60% during the hospital admission. And what did they find? The basically is that by doing the FFR guided PCI versus angio guided PCI, your event rate was half. So this is like anything which we have. Otherwise also in our PCI group without TAVR, and the same thing happened that FFR is better. Now there is a trial which combine whether you should do patient who is appropriate, CABG plus surgical valve replacement, or PCI plus TAVR, and this is called TCW trial, and basically showed that FFR guided PCI and TAVI was have low event rate compared to SAVR and CABG. A small group, but this is the field. We have trial ongoing called complete TAVR trial, which is a 4,000 patient trial where PCI versus no PCI and trial ongoing. Then mitral valve intervention, this field I would just go through it with the mitral clip, mitral valve the replacement. This field is still complex, and yet after so many years of 10, 12 years of work, we have not come up with any good valve design. So of course, TR we use, TMVR you use where the various valves here, and Sapien M3 seems to have a very good data which were presented, and they actually likely will get approval in first, second quarter of next year. And this basically is a little different design. So two part, that first you put the dock and then you put a valve inside. Seems to be working quite good with Edward. That Alta valve, which fills up the left atrium, and then there's high life valve, and the already received the FDA has approved the particular tendine on a patient with a MAC, but it's an open surgical procedure. The Apollo trial, which is the Intrepid, which is V part of it, very difficult to enroll these patients, but work very well in selected cases. As you can see here, and 2-year outcome were presented by Gilbert Tang, that overall these patients are high risk, but they do quite well subsequently. And the good valve duration, and no paravalvular regurgitation. Question always come, when you put these TMVR devices, that you should use anti-thrombotic therapy, oral anticoagulation or NOAC, because antiplatelet therapy alone is not enough. So then question comes that now you have everything available. 3 things, surgery, TAVR, the TMVR and TR. And what is happening basically is that clearly that surgery is, numbers are going down, but now the MTR, which is the tricuspid with the mitral clip, is increasing, and the TMVR, which is very small but also increasing. So that is happening, and of course, based on the patient frailty, outcomes are different. But patients, appropriate patient who has mitral disease, the low risk, they go for surgery. High risk, they go for either TR or selected cases with TMVR. So TMVR is done in very small number of patients and so. So then there are few trials are ongoing which will answer the question. MITRA, HR, primary trial, repair, MR trial, all they will answer MTR in various selected groups. So then tricuspid valve intervention, the triluminate, the various devices are available. And of course, some got FDA approval, both TriClip as well as the Evoke, both have been approved. And so very good device, particularly Evoke, that full replacement of uh, the tricuspid valve compared to the mitral, where we have not come up with any clear-cut device. Here, Evoke works quite well, and we actually have a good experience. We published the data, Safi from our group, in terms of the technique of this valve deployment. And now we actually have the pivotal trial of the randomized Transcend Evoke versus optimal medical therapy alone. Overall, no difference in the major endpoint, but quality of life. Readmission at follow-up was slightly lower in the Evoke group. So clearly you have some treatment for these patients which are otherwise not getting any treatment, but pacemakers still remain the issue. The Triluminate, which is the first one, or the TriClip, is doing quite good up to the 2-year data and follow-up. Then the last one, before the last comes is your valve durability. That is the low risk aortic stenosis. Are we as good as surgery in terms of valve duration? So we know that now we have the Notion 10 trial, the Notion trial, 10-year data, low risk, bioprosthetic valve degeneration, and outcome identical with the tower and surgery. Then we have the 5-year of the Evolute, low risk, again, similar outcome at follow-up, and the valve degeneration and thrombosis similar. And so now we actually have 7-year data of the Sapien the valve versus surgery in patients with the low stenosis, the low risk aortic stenosis, and outcomes again comparable, if not better, in these cases. And there is no issue in terms of the valve degeneration. Thrombosis, there's slightly increased valve thrombosis, but reintervention was identical, and valve degeneration is same. So you can always say now, cases when we compare the tower versus surgery, 7 to 10 years seems to be a good in terms of valve degeneration. Now, we also learned asymptomatic patient, when you watch them, they may develop sudden deterioration. We call it progressive valve syndrome or acute valve syndrome. If you patient, AS you follow, knowing that the guidelines were that you cannot treat them, cannot do the tower or surgery because guidelines were not class 1. So those patients, many of them can deteriorate, and then they have bad outcome. So idea there is now that asymptomatic patient, based on the two tower trial and 2 surgical trial, should undergo the valve replacement, whether surgery or with a tower. So European guidelines are always ahead of the ACC. They came up with the new guidelines this year, just a few months ago, of the valvular heart disease, clearly emphasizing on the heart team member decision. And then ultimately the patient. The valve centers, the complex cases should go to the valve center. And of course, all the imaging studies has to be part of it. And then discussion with the patient and family. Ultimate decision has to be still the family. Same patient, same issue with our complex cases in PCI. No matter what the guidelines and trials show, the decision has to be done by the patient-centric and the family-centric, and that's what you present the data, and then patient should and family should decide. So patient-centered evaluation, after we decide as a heart team that what is the right, and many time patients say, whatever you are doing, but from our point of view, patient should get tower or should go for surgery, and so we had to take their in consideration. So now the question remains asymptomatic, despite the 2 tower trials and 2 surgical trials showing benefit, they still remain 2A. So this is, and then also patients who have a bicuspid aortic stenosis, TAVI may be considered as a 2B, because this is the one still, I would say, Achilles heel of the tower, that you need to have a randomized trial, and that is being planned by Raj Makkar and so, and we'll be part of it. The mitral regurgitation and other indications, I just put it here, they all are reasonable. One actually is good, that now the TEER has become class 1. Patients with a reduced heart failure because of the multiple trials showing benefit of TEER in patients with secondary mitral regurgitation and ejection fraction less than 50%, that they live longer, less hospitalization, and that is what basically has been shown as the guidelines. So in AR patient, they actually have come up that you can have a transcatheter valve in some cases where there is no surgical option, but not definitely guideline point of view. The other point is basically the patient with the primary MR that you have to have the high risk anatomy, high risk for surgery before go for a TEER. But in cases with the secondary MR, lot of liberality in terms of indication for TR in the trial. Now, another the key question comes is for the tricuspid. Finally, they have first time in the literature the transcatheter therapy where no other treatment is available is recommended now. Also important, and this is a very big time from various trials. Our current practice now is post-hour we give aspirin lifelong and clopidogrel for 3 months. And now you see this trial has eliminated clopidogrel completely. Aspirin for 1 year, and maybe after 1 year is a 2A. So, but aspirin alone not needed if you don't need for the PCI. So, if pure tower, aspirin alone is the way to go. And of course, if you do a TMVR, you need anticoagulation. So, with that note, these are our top 10 advances. So, I just put it together, and I'll conclude very quickly now. So, what we learned: cerebral protection devices during tower, no good, 2 thumbs down. Then newer tower devices, newer mitral devices, plus minus, some small numbers, nothing exciting, which is coming to the line showing the randomized trials data yet. Then the tower over Sauer in all comer and female, small in a self-expanding valve in a small annuli, and 8 French tower, and tower under conscious sedation. I think this is 1 thumb up. Then TriClip at 2 years, TTVR evoke, FFR guided PCI pre-tower, SGLT2 inhibitor post-TAVI, and 2025 European guidelines, basically 2 thumbs up because they definitely are exciting data and more importantly, guidance for us. Then the tower durability, that is the key, I would say the most important what we learn is that PCI and tower versus surgery, and then some data of the valvular guideline, particularly making as a class 1 for the TEER is make it a 3 thumbs up. Idea there is to become better interventionalist and so. The field will continue to evolve, and this is my prediction that right now we do a lot of PCI, which is the yellow. That number, because of all these medications, overall, revascularization. In America, surgical and PCI going down because of the aggressive medical therapy. And I think the structural area is the one which is going to improve further and so. And we actually continue to do our teaching. Every week now we have some kind of a teaching with the third Tuesday our coronary, fourth Wednesday is peripheral, second Tuesday is the structural case which we just did, and the next case will be, and we have about 20,000 hits per month. It has been very, very successful. TMVR case will be relayed on 1/14/26 actually at 9 a.m. But the whole purpose is that try to do more complex cases and at ease, go through 1 hour various case presentation, case performance, and some didactic discussion. With that note, I stop here and thank you very much.